the SAMHSA mentoring program, which is called the Physician Clinical Support System. And that exists for physicians who want to learn more about practicing medicine in the area of addiction medicine, but they're already out and about, and perhaps primary care physicians or other types of physicians, and they just need someone to kind of guide them along. I actually went on this website yesterday, and I'm not a physician, and it's really easy to use. I was like one click away from requesting support for myself, which would be you. So it's, there's really not an excuse other than people don't know about it. And there are physicians who serve as mentors from all kinds of backgrounds, from primary care to psychiatry to OBGYNs, you name it. And they give you a list of the mentors' professions, their geographic area, their specialties, so people can really pick and choose the mentor for them. Their difficulty is the idea of difficult patients. As I said, I'm not a practicing physician, so this was kind of a surprising one for me when I first started doing this research a couple of years ago. I just hear over and over again, these are really tough patients to deal with. I don't want to deal with them. And this is a really interesting concept because, yes, we do have evidence, of course, that these are difficult patients, especially the fact that many of them will lie, many of them will manipulate. The problem is that there are other types of difficult patients and other difficult diseases, and I don't really think that this is talked about much in the context of other diseases. So what is the difference? I think part of it is education, of course. Part of it is perhaps stigmatization of these patients. And part of it is not viewing things like lying and manipulation as symptoms of a disease, but rather viewing them as signs of being a bad person, which thereby puts the physician kind of on guard, not expressing that empathy, which we know is important, and thereby making the whole process unpleasant for everyone involved. Another concept that I hear is patients are difficult just because they're complex. So they may come in with co-occurring mental disorders, or they may come in with co-occurring physical disorders like HIV or hepatitis C. Again, this is partly an educational issue, but for certain providers like primary care physicians, this may be a matter of referring out to those patients who are complex, rather than simply assuming from the get-go, all patients are complex, I can't deal with any of them. So one element, or one way to approach this, and I'm sure there's others, is to just increase interpersonal skills training. So I talked about education in medical schools. One thing I didn't mention is this really needs to be hands-on. That's what we know from studies. Physicians need to have time to practice this, whether it's on actors, whether it's on each other, on a virtual patient. They need to practice these interpersonal skills because some of these skills are not purely medical skills, right? So, this is again where a mentor may come in. One thing that I saw that was interesting is some medical schools are using small groups to debrief with their mentors after encountering difficult patients, especially in acute care settings or inpatient settings, to kind of discuss the different angles of the problem, but also to become more sympathetic. And what the studies have found is that these small group settings where they're debriefing and talking about the issue actually leads to increases in empathy and increase in a feeling of, I enjoy doing this. So at least in the medical school time, this may be an important idea to adopt. So very relatedly, there is definitely stigmatization going on, and it goes both ways. So I see stigmatization in terms of physicians stigmatizing patients, but very interestingly, and again, was not aware of this until a few years ago, I see physicians stigmatizing each other. So I will get into this. One thing that we know is that when physicians view patients negatively, then they are less willing to treat them, and that leads to worse clinical outcomes. So clearly stigmatization, if not just for ethical reasons, for practical medical reasons, matters and needs to be addressed. But another thing I see often is physicians being worried about their mix of patients. In fact, studies show that that is one of the main barriers to physicians beginning to treat addiction medicine. They will say, I don't want that mix of patients. I don't want to be known as the addiction doctor. And again, I'm not really sure how to justify that, especially given that we have so few physicians treating addiction right now. Again, this may be a matter of education. It may be a matter of physicians pressuring each other to, say these are not good attitudes, these are not ethical attitudes. And in particular, there's really heightened stigma towards individuals who are injection drug users. So one thing that I read that is quite important is for mentors to demonstrate lack of stigma. And this goes even kind of down the chain. So residents who demonstrate stigma have been shown to increase stigma perceptions among medical students, and the clinical medical students in those years will demonstrate it to the preclinical medical students. So there's a chain reaction of stigma that occurs in just the education process itself. But another thing that a lot of times is often overlooked beyond education is just increasing contact with patients with addiction in general. So we know from various studies, even outside of medicine, that the #1 way to decrease stigma towards a group is simply to increase contact with that group. Now, I already mentioned physicians are frequently contacting this group. They just don't even know that they're contacting this group. So part of it is making physicians aware that, hey, you actually are seeing a lot of these patients and they are normal human beings. But part of it is also getting more of these patients to enter offices, and that may be a matter, for example, of having less regulations on some of these medicines, or having the physicians be better educated and more comfortable in saying, I want to open my doors to patients with addiction. All right, one other really common barrier that I hear about is this idea that only psychiatrists should treat addiction. And this can kind of be a touchy topic, interestingly, when I interview some physicians. We know that primary care physicians can do a perfectly fine job treating physicians given education, given the right resources, such as contact with counselors and mental health professionals. So yes, it may be harder for a primary care physician starting at, say, ground zero to build up to that standpoint where they have the level of comfort and the level of education to treat addiction, but it's certainly not impossible. And yet sometimes I do hear this rhetoric, especially among psychiatrists, that this is something that should be really left up to the psychiatrist. Ideally, I love that idea. I think psychiatrists are brilliant, and if I were to go back to medical school, I would become a psychiatrist, but we simply don't have enough of them, and we have an overdose epidemic, so we have to look at other types of physicians to treat this issue. We also know that primary care physicians are ideally placed in that they're geographically dispersed. They have lower costs. They are often the gatekeepers for insurances. Insurance saying you have to go to them first before, say, you go to a psychiatrist. They know the person's family history and have perhaps seen them for years, so they may be the first ones to notice something is a little off here. And also there's a total lack of stigma of someone going to a primary care physician where there still is, unfortunately, some stigma of being seen walking into a psychiatrist's office. Unfortunately, buprenorphine waiver distribution is really low if we look specifically at primary care physicians. Only 3% of all primary care physicians have obtained a buprenorphine certification waiver. And again, this probably is even lower for how many physicians are actually treating addiction with something like Vivitrol, even though you don't need a waiver for that. So one solution is simply to encourage interaction between primary care physicians and psychiatrists. And this is a model that was used in Vermont, and this may in fact be the reason that Vermont has so many more accessible providers than the rest of the United States do. So the way this hub and spoke model works, it's very intuitive. So obviously it can be very harmful to the patient if someone else, maybe a coworker, sees them entering the super specialized addiction clinic that might as well have, you know, plastered on your forehead, I am a drug user. So what can we do about this? Well, first, let's stop treating MAT so differently. Maybe it should still have some additional barriers relative to other medications. I don't know, but at least not the level that exists now, especially for methadone. We have examples from other nations. We are the only developed nation that regulates methadone to this extent. So we have Scotland, Canada, Australia, the Netherlands, England, you name it. They have moved to a completely different system. There are no methadone clinics per se. General practitioners can prescribe methadone, and if they have complex patients, they send those patients to specialists. There are some areas, like in Scotland, where they work together. So it's actually a joint partnership between the specialist and the primary care physician, and they have to come up with the plan together, and they have monthly consultations between each other for patients on methadone. So there are definitely other options, and I'm not saying any of these are perfect, but I think it's definitely time for us to start looking at some other options. Another important thing that would occur if we moved some more patients into the physician's office and out of the methadone clinic is to have physicians actually seeing these patients, seeing them as normal people, seeing this as a normal medication. And finally, from a regulatory standpoint, I think it's important for the federal government to clarify the rule regarding needing to have the ability to refer patients to counseling if the patient is getting buprenorphine. I have heard anecdotally and also in some of my interviews, and I have not seen any large study on it, but I've heard sometimes that physicians are concerned that I can't prescribe buprenorphine because I don't have enough time to provide counseling myself. That's not what the rule says. The rule doesn't even actually say the patient has to have counseling, although that's probably the ideal. But I think some clarification on this rule needs to be made. So, am I doing on time? I'm way over time apparently, so I'm going to stop here. As you can see, there's a lot of barriers. Thank you very much. If you have any questions, I'm really eager to hear them, and also please email me. I'm actually going to fast forward to the side here with my email. If you have any comments, any ideas, please send them to me. Thank you very much.